Hello, I'm Jessica Lovell, and happy holidays from the Morning Medical Update team. We are taking some time off to spend with friends and family over the winter holidays, and we sure hope that you are doing the same. Until we return with our live programming on February 2nd, please enjoy this Encore presentation of one of our very favorite episodes.
Coming up today, from a reading coach to a cancer coach, one woman's decade-long journey with multiple myeloma and the message for others facing that same journey. Good morning, I'm Alexis Del Cid. Welcome to the Morning Medical Update. Cancer in general is more treatable and more survivable than ever. That is thanks in a large part to the patients who are willing to join clinical trials and advance medical science. Lou Sears is one of those patients. Jessica Lovell shows us.
It was 2013 when Lou Sears, a beloved teacher and reading specialist, was driving home from school one afternoon when suddenly she realized something wasn't right.
I immediately felt overwhelmed with fatigue. It came on very quickly.
When her husband David got home, he found his wife in a disoriented state with a temperature of 103.5. He immediately took her to the emergency department. Doctors ran tests. Her blood pressure was dropping and her organs were starting to shut down.
I found out later from nurses and doctors they thought they were going to lose me.
Lou recovered after 5 days with antibiotics and steroids, but doctors were concerned about the elevated protein levels in Lou's blood, so they referred her to a hematologist. When Lou and David arrived at the appointment, it's not what they heard, but what they saw. They knew life was about to change.
We were expecting to see, like doctor's offices, the big building, you walk in and nothing on the outside other than maybe KU, but it specifically said Cancer Center. So we both were looking at each other and we were like, what? It was the first time we had been really introduced to the idea that we're dealing with cancer.
Specifically, her doctors at the University of Kansas Cancer Center explained that she had multiple myeloma, a type of blood cancer, and would ultimately need a stem cell transplant.
It was just such an overwhelming experience to learn that you have something that really, it still is not considered curable.
It was devastating when she was first diagnosed, obviously, and we had never heard of multiple myeloma, didn't know what to expect, and the prognosis at that time was not good.
Lou went on to have her transplant. That was 12 years ago. Since then, she's considered to be in partial remission. She thanks her KU team and her husband.
I wouldn't be here without him. I've said many times to him, you've saved my life.
But she's more than a cancer survivor. She's an educator. Lou mentors other cancer patients and is a recently published author.
It was after school on a Thursday before Mother's Day weekend.
Using her story and strength to help carry others through the same journey.
She's just a wonderful person and very courageous and kind of my soulmate.
Thank you for being here, and what such a beautiful way you speak about your relationship. And we also have Dr. Al-Ola Abdallah, a hematologist and oncologist at the University of Kansas Cancer Center. He's also the director of the Plasma Cell Disorder Clinic and the president of the U.S. Myeloma Innovations Research Collaborative. So you're not busy at all. You've got a lot of free time on your hands. Dr. Abdallah, let's get right into it because we have an image helping explain multiple myeloma because so many people have never heard of this one. David, you said you'd never heard of it.
No,
Lou,
neither of us.
never heard of multiple myeloma. So, doctor, how does a normal plasma cell compare to a multiple myeloma cell?
Absolutely. I think that's a very important question for a lot of people to understand that, is that our body contains plasma cells, and you can consider it as our soldiers that produce antibodies like missiles to attack infections, whether it's viruses, bacterial, or fungal infection. So that's normally these antibodies, protect us from that. There's a system that this plasma cell worked, and based on the system, it functioned well. It produces many of these plasma cells when you have any infection, and produce these antibodies, which is made, by the way, from proteins, and get rid of the infection. And then after that, these plasma cells go back to their bases, and everything is fine. Now, the problem here is that what happened in myeloma, unfortunately, some of these plasma cells become sick, or you can call like not oriented anymore, and they start producing defective antibodies, not really effective antibodies. These antibodies is more than produced than expected, and that will cause a lot of harm, because these are not supposed to they're not supposed to produce this amount of antibodies, and these bad proteins will go to the kidneys, causes kidney damages, go to the bones and causes bone damages, and also can impact the factory of the bone marrow and causes bone marrow failure, so your patients can get anemia and even more infections. So this is what we call it multiple myeloma when it happens. So these plasma cells are supposed to be protective. Some of it gets sick, and we don't know exactly the actual cause. Is it genetic? Is it exposure to chemicals, pesticides? We have 100% no clue exactly what is it causing it.
So it could be environmental, it could be...
It could be environmental. There is some suggestion about that, because we have seen it in some patients who got exposed in the past for pesticides or incidents.
Okay, and then it's considered manageable but not curable.
Correct.
Why can't it be cured?
Yeah, I think it's a very important thing to understand how the history of the myeloma. The good news about myeloma, and Lou knows about it, like maybe 30 years, I'll say, or 40 years, we used to tell a myeloma patient you have only 2 years to live.
Oh my goodness.
And the reason of that, because it's not about it's curable. The myeloma, we didn't have a lot of great options of therapy. We treat the patient, they go to remission, and they relapse. The great news is that now we have many options of therapy. So from 2 years of survival to about 15 years with our current treatment, and all these treatments really helped a lot. Patients like Lou, Sears, and many patients to survive longer. So that's a very great thing. You're right about one thing, is that is it curable? It's curable maybe in 20%, 30% of the patients, but 70% will still relapse. And there is a theory about that the myeloma cells know exactly how to come back again, how to learn from the treatment. But the good news is, as I tell Lou, Sears, is that comparing to 30 years ago, we didn't have a lot of options. So you finish your first option, we're done. We don't have many. But now we have many options that we can keep the patient in remission, and if they get out of remission, we can keep them, we can bring them back to remission. We have really great therapies, cellular therapies, immunotherapy treatments that had helped a lot of patients, such as Lou, Sears, and many, to actually not only have a good quality of life. So I would say, although it's not a curable, we are talking about a disease that is becoming like diabetes and hypertension, a chronic disease. You can live with it and you can get treatment. But I think we have to be a little bit optimistic. You move from 2 years to 15 years. So are we heading to the cure? I think we are. And I hope that we will start seeing more and more studies to show that we can cure myeloma.
And Lou, as you describe it, you're living with it. You're not... You are living with multiple myeloma, like living with diabetes or living with something, which is such a unique phrase to hear when you compare it to what we used to hear 30, 40 years ago.
Yes.
How are you feeling physically today?
Good. I think just fatigue, that comes and goes. But overall, I think our quality of life is good, and we get to do what we want to do with our family, travel. There isn't a lot that we can't do. It's just you don't stop living because you have multiple myeloma. You keep on with your life.
And David, you're nodding your head yes.
Yeah, I think we do very well as far as not stepping back from life, but becoming engaged with it. And Lou does a great job of being an advocate for other multiple myeloma patients.
As a cancer coach.
As a cancer coach.
We're going to get into that in a second. Lou, I do want to ask you, you talk about that moment when everything changed. You're driving and you feel tired, you have a high fever. Had there been any sort of symptoms looking back that were happening before that moment? Or was that the first sign something was wrong?
I didn't have anything going on before that day that I was driving home and got to the house. I didn't know that I would. I thought I might have to call David to come and pick me up. But I did make it home, fell asleep on the couch, and when he got home, I had 103.4 temperature, and I was perfectly fine at school that day.
Oh my gosh.
I taught all day. I had no cold, no symptoms, no flu, nothing that would indicate that I had something going on in my body.
I would have just thought it was a terrible case of the flu if I was in your shoes, or if I was David seeing his wife like that. Dr. Abdullah, is that a normal way that this presents, just out of the blue? You feel like you're getting the flu and you're diagnosed with this?
That's a great question, and kind of like what Lou was describing is one of the presentations. Like there's many presentations patients can actually have. Infection is one of them. Other presentations could be bone pain. That patients come by. Unpredicted fractures, patients get admitted to the hospital for other reasons, and they found that they have a high creatinine, which is a kidney function, and their kidneys are failing, so they do more workup. Patients are anemic, like fatigue, major fatigue, that their blood levels is low. But now we are, and I think as I was telling everybody about like 30 years ago, now we're advancing, we're realizing the myeloma, as much as it's not very common like other breast cancer or lung cancers, but we are more organized about knowing exactly if the high protein level, it could be a myeloma or a plasma cell disorder. So we are seeing also patients who are asymptomatic, not having any symptom, and we're diagnosing them before these symptoms are actually hitting the patients. So that's one of the things about it.
So I want to ask this to both of you. You're a team. You're the same, almost like I get the vibe you're the same person, just two halves of the same person from the way you describe your relationship. So David, what does a good day for Lou look like to you?
She's energetic, engaged in taking care of family issues and planning for the future, talking to other myeloma survivors and patients, and just cooking and doing all the things.
Yourself.
Yeah, she reads, and so she has hobbies that she gets engaged in, and so she's living her life, basically.
A good day looks like Lou being Lou.
Yes, absolutely.
Yeah.
And I can tell when she's not feeling really great.
And that's what I want to ask Lou. How many ups and downs have you been through over the past 12 years since your diagnosis?
There have been so many as far as relapses, remissions, but I think this is something that with Dr. Abdullah and his team is learning to accept what happens as it comes and meet it head on, and then research, find out what's available next. And I think that saying what's next has become a mantra, for us, is when one treatment stops working, is what's next. And we are so lucky that there are treatments available, because that wasn't the case a few years ago. When we first started this journey, I was told 3 to 5 years.
And now it's been 12. 12 and counting.
12 plus.
Those treatments they're really cool in the way you describe it, as little soldiers going in to fight what's wrong. Lou has benefited, Dr. Abdullah, from some of the newest cellular therapies available. So today we want to talk about 2 of those therapies. First, we've talked about CAR T a lot. That's when doctors take a patient's own immune cells and then engineer those cells to fight cancer. Can you explain how it is you engineer those cells and get them to be better soldiers going back in?
Absolutely. I think the best thing about this is that we have to understand, like, again, we went back to, in the old days that chemotherapy, stem cell transplant was the only option. And then we realized our own body have the best, actually, treatment system for most of the blood cancers, which is CAR T cell. It's your own immune system. So blood cancers, specifically find a way to hide from our own T cells. The T cells is supposed to kill the infection and also kill cancer. So when they hide their way, some scientists realize exactly, what if I actually try to put something like a laser tag on it to find the cancer cells and kill it? That's supposed to do. So what they do is that they take all these T cells from patients like Sears, and they will modify it. They put like something, either a GPS, I call it a laser tag, like, you know, they know exactly what they want to target. For example, in myeloma, we have a very, very important tag called BCMA. It's present 95%. This tag is very important because it's like where, you know, where you can locate with it. So once we have these T cells and we put that laser tag, they make millions and millions of these T cells and then bring it here. We take patients like Lou, we give her a small dose of chemotherapy just to move other T cells so we can give it room.
To like clear the field?
Clear the field.
Okay.
And then we infuse all the CAR T. And the CAR T, what it does is that go ahead, find wherever the myeloma, like a GBS, and attach to the myeloma cells, produce cytokines, which is the bullets, and go and attack the myeloma cells and kill it. So that's how it does. And the response rate is amazing. Like, it's like you're talking about this only one treatment is 80 to 95%. That's a very good response rate, and it's a one-time treatment. So it kind of like show you exactly how your own body, I mean, it's if you actually look at it, it's your own T cells, it's your own immune system. What we did is just redirect them. Okay, you know what? I know you're not able to find the myeloma cells. I can give you a tool to find it. That's what we are just doing.
That is the best description I have ever heard as someone without a medical background. It's as, when you came in not knowing what multiple myeloma was, did it help to have someone like Dr. Abdallah explain it?
Absolutely, absolutely. I mean, without his help and the other medical team with him, it would be impossible, I think, to really comprehend, you know, how this works. You know, the CAR T itself, learning how, you know, it can be reprogrammed and attached or send things out that kill the myeloma cell, you know, the targets, attaching it is just incredible. I mean, when you think about the science of it, it's really amazing, and it is such a game changer for patients like me.
Then there's another kind of therapy we want to talk about. It's similar but different. It's called BiTE therapy.
Yes.
So what does BiTE stand for, and how does that work?
Absolutely. I mean, that was another great thing. I mean, it's a bispecific T cell engager. So to break it up is that some scientists say, you know what, Lou is very lucky, by the way, she got the CAR T cell, but there are patients who can't get the CAR T cell for many reasons, you know, and you know, it might take a long to talk about it, you know, but so one of the things is that they realize that what if we have a tool like an antibody, a mediator, like a middleman, so you can call it, that will actually give it to the patient, infuse it, and instead of taking the T cells out, you know, this is going to be the GPS. This is going to go ahead and have two arms, an arm that attached to the myeloma cells, like the BCMA, and an arm attached to the T cells of your own body without taking it out, and make it close together so that the T cells will produce the cytokines the same way and attack the myeloma cells. So that's how the bispecific works. So it's a drug. It doesn't kill the cancer cell. It just go ahead and show your T cells how to attack the cancer cells.
How do you decide who gets which therapy?
Oh, that's a good question. I mean, and that's the biggest debate. Now, I think CAR T cell is above the bispecific because it has more trials. It's more advanced. We have more randomized trials, so we know how much is it effective comparing to standard of care. Bispecific is, I can say, it's a little bit two steps away from the CAR T cell. We are still trying to understand how we can combine it, how we can maximize the impact. And number two, I tell a lot of patients the reason if I want to choose the CAR T cell, it's quality of life. You know, Lou get the treatment. She doesn't need to come every week or every 2 weeks to get any injections. While the bispecific treatment, you have to give a weekly treatment. So, I mean, if you look at the quality of life, I prefer to give her one treatment so that she can enjoy her life and going outside, you know, with family and traveling and etc.
David, how did you and Lou decide to come to the University of Kansas Cancer Center and see Dr. Abdallah?
Well, we did a lot of research, she and particularly Lou, and we discovered that it was as good as any other facility that was available, and we could have traveled, but we didn't find it necessary because KU was doing everything that was at the cutting edge of what was going on with
and I looked at the response rates, you know, the patient response rates in of the major hospitals. You know, I looked at, you know, Mayo and
Across
MD
the
Anderson,
country.
because David said, we'll go anywhere, wherever is the best treatment possible. I said, let me research. So I researched. Being an educator, it's really important to me to research and know and go to reliable sources. And that's what I did. And when I came up with the numbers and what they talked about, KU was right up there with the rest of them, and I thought, why travel?
When you don't have to.
Yeah, we live in the summits, so it's just a very short drive, really. And so we didn't have to spend time outside of where we can have our family and have activities that we enjoy. So
And support.
And once again, that allows you to live your lives as normally as possible while you're going through this. We have some great questions and comments that are already coming in. If you have a question or a comment that you would like us to read out loud on this show, just send it to us right now. You can connect with us in real time on the links that are on your screen, KU Hospital, on Facebook, on Instagram, or the Medical News Network. That information is right there. And we do have a question from Nate Gold. From Jean Reardon. Nate sent me this question from Jean Reardon. Jean writes, is anemia a symptom of this disease, and can you have anemia separate from multiple myeloma?
Well, I mean, it's not all the time there. I mean, it depends exactly. It is, if it's there and it's related, it confirms the diagnosis of myeloma. Can you have anemia separate from myeloma? Yeah, absolutely. There's other reasons for that, many reasons. It could be deficiency of minerals like iron deficiency, vitamin B12 deficiency, and it could be chronic disease. If patients have chronic disease from rheumatoid arthritis or any other kidney disease. So anemia is not always necessary to be associated with myeloma, but it is like a key. If it is associated, it's one of the parts that confirm the diagnosis of myeloma.
Did you have anemia?
At different times I have in my blood tests.
Jean has another question. This is a great one. Is this covered by insurance? Do you ever get pushback when it comes to insurance?
You're talking about CAR T-cell?
CAR T or BiTE therapy?
Yeah, that's a great question, and I think the best answer I can give is that if we have guidelines by the NCCN guidelines that we have to follow. So, for example, you can give CAR T-cell in the second line of therapy, but if the patient like in a first line, like just wants to start treatment and say you want to do CAR T-cell, we can't get that, approved. So it's approved if the patient failed the first line of therapy, which is, I think, the majority of the patients, unfortunately. Regarding the bispecific, you have to fail like at least 3 different treatments before you actually consider for the bispecific treatment.
Okay.
We do not get push-ups if the patient meets that criteria, but if we do, we try to talk to the insurance and try to find a way in order to kind of like make sure that we have appropriate reasons why we want to use this treatment.
And we do have some more questions coming in, but first I want to get to some more that we have for you, Lou. You're a cancer coach.
Yes.
A cancer coach, which I haven't heard of that kind of a coach before. It's an awesome term. And are you the co-coach?
Yeah, yes,
the assistant coach?
The assistant coach.
You help people who face these very stressful diagnoses. What does coaching look like when someone comes to you?
We get referrals. Our coaching is informally started through our support group, our IMF support group in town.
What does IMF stand for?
International Myeloma Foundation.
Got it. So your support group.
It's sponsored, sponsors our support group. And I would get referrals, from the leaders in the group who said, hey, Lou, somebody, in the group wants to talk to someone. And so that's how it all started. And then I heard that through HealthTree, which is another organization that helps patients with myeloma and now leukemia, they have coaches. And so I signed up for it, and then David signed up, and you go through training, and you learn how to be a good listener. You don't want to be judgmental, nothing, and you're not a medical person. You're just there to listen. And oftentimes it's people who are newly diagnosed, and they're scared, just like we were. Mm-hmm. When we got the diagnosis, it was just like shock, and we stood in the hallway and hugged each other and cried. Because it was just like, oh my gosh, this is changing our lives now.
Yes.
And that's how these other people feel. And knowing that we have moved through that and can encourage others, you know, and give them hope. You know, that's like the title of our book, you know, Living with Hope. We live that, you know, and we don't go and hide in the corner and say, oh, I have this, you know, disease. I'm going to just stay here. I don't want to get out. I don't want to do anything. And we don't see our lives as that. And that's what we try to encourage the people we coach.
Can you hold up your book for our viewers to that camera right there so we can get a good shot of it? When did you write that book?
Over 12 years.
Over the course of the past 12 years, called Living with Hope.
Yes, over 12 years.
And are you hold it, keep holding it up. They got you right there.
I'm
That's
sorry.
A good shot of the book. You and David co-wrote this book?
Yeah, I started it in a Caring Bridge website that allows you to journal, and then you can share. It's like a diary, and then you can share with family, friends, you know, on Facebook, whatever, to let your friends know how things are going. So I started that like the very month after my diagnosis. I started keeping it, and so David and I, along the years, have said we should publish this. You know, we should make this into a book. Maybe it could help others, and so that's what we did this year. When I was waiting for this last CAR-T, it was on hold for a little while, and I said, I feel stuck. I feel like we can't move forward, you know, because we didn't know, is this CAR-T going to be kept on hold, or is it going to free up and we get to go forward? And David said, you know, he could tell that I was so frustrated. He said, write the book. Let's start the book. And we did in April. We put it together. David was looking at it, editing, and then he wrote the afterword, and it was, I mean, so touching. You know, for me to read it, I was just like sobbing, because it was letting me know what it was like for him as a care partner.
One thing I want to ask you is, you make a point of telling people, don't be a passive patient. You consider yourself, and David, you consider yourself to be active participants with the care team.
Yes.
Absolutely. Yeah.
Why is that so important, and what do you do to be an active participant in your own treatment?
Well, as Dr. Abdallah knows, when we come in, we always have lots of questions.
Right. You bring a notepad in with your questions.
Yeah, right. And we'll bombard him with our questions.
I bet you like that, though.
He's so good.
Yeah.
Though. He's so good to answer everything that we have, and sometimes it'll be treatments that I've heard of, you know, through my coaching connections, you know, throughout the United States. And I'll say, you know, I heard about this bispecific, or I heard about this CAR-T, and what about it? And he'll let me know, you know, more information and whether or not it would be appropriate for me. And it's that conversation that we can have that helps, I think, helps me feel a part of, you know, the decision making. And Dr. Abdallah and his team, they are so good to make you feel, as a patient, a part of your team. He wants any questions. He wants to know if you have concerns or anxieties or worries about anything. And he's such a patient advocate. You know, he makes you feel like it's okay to ask as many questions as you have.
Right. He volunteers to come and talk to our support group. He'll actually reach out and want to speak to the support group. And one of the things that we learned as coaches was that it's important to have a myeloma specialist. And the program here has grown so much and is providing a great service for the people that are suffering from this disease.
We have an interesting question from John. John wants to know what the CAR-T therapy feels like to you, because Dr. Abdallah describes it as a battlefield. Do you feel any action happening inside you after that treatment?
I know you have these little warrior T cells.
Yeah.
You don't physically feel that. There are things that happen, you know, that let you know that they are working or that they are fighting.
Like what?
You know, the myeloma. It could be when you're in the hospital, it could be like low-grade fever. Some of your numbers, your lab numbers, let the doctors know, you know, is it working? Is it looking like, you know, what things we know to look for is happening with this patient. But physically, I don't feel the battle.
The battlefield.
Inside, after I usually, after the week or two when you get out of the hospital, I think fatigue for me seems to be the thing, but I wouldn't really describe that as feeling the battle within.
Your body's very busy.
Yes.
It's just very busy.
Yes,
so
and it gets tired.
Yes. It's fighting war.
Yes.
This part is so amazing, Lou. You are on our Wall of Hope at the KU Cancer Center in Westwood. Dr. Abdallah, how did Lou wind up on the Wall of Hope?
Well, I mean, first of all, Lou is one of the great patients who also helped a lot to, kind of like Tisha's patients as well. She volunteers a lot for many of our patients and support them, which is very important. And also not that like that. Also, she's advocate for a lot of clinical trials. We have to kind of give that. Lou is a very, this is a courage, by the way. It takes courage. You come to a patient, you say, you know what, I don't have a really great options. I have a clinical trial. They don't want that because they are scared that the clinical trial is not effective. But we have to understand why clinical trials, the clinical trials are the reason why we're now here. The clinical trials are the reason why we moved from 2-year survival to 15-year survival. That was the clinical trials that got us more CAR T cells and bispecific. So patients like Lou helped us a lot to get into enroll in clinical trials. They helped to actually advance medicine in myeloma, especially in myeloma and blood cancer. So, actually she deserved it, because thanks for her, that helped us a lot to advance our treatments for myeloma and for the future patients that we're close. Maybe we're not right now in the cure zone completely, but I think we're getting more closer to announce that we can cure myeloma with this type of treatments.
And Lou, you're part of that.
Yes, I've had 5 clinical trials.
5?
5. Yeah.
That's amazing.
Yeah.
David, hats off as the care partner.
I'm sorry, say that.
I said hats off as the care partner because you are a true partner.
We have done 5
Yes,
clinical
you've been through it together. It's time for today's takeaways, and I want to start with Lou. What would be your message to our viewers, to people watching right now?
To live with hope. That's why we titled our book Living with Hope, because I think so many times people, when they're diagnosed, they feel, like I said before, scared and think their lives are not going to be anything like it was before. Like travel and doing things with family and being able to see their kids get married or graduations and things like that. I think they have this view that they're not going to be able to go to those things. And I think for us, that's what we want.
Yeah, you have a bunco group that you...
A bunco group.
Hey,
oh,
it's
that's
another
fun.
support. I have lots of support systems.
I want to go to bunco night.
They're wonderful.
Sounds like fun.
Just once a month, but we're fine. And they are so supportive. That's another system,
Emotional
and that's what
support.
I let them know. So my takeaway for people is find your support. Whether it's family, friends, or, people within your own, home, your brothers, your sisters, whoever it might be. Could be through your church or wherever, because there are some people that are single and they need to have, a support system.
David, what about you? What would be your message to people watching?
Be sure and educate yourself about what the treatment options are. Don't be afraid to ask questions. Because like with Dr. Abdallah, you can ask any question, and I would assume that all good doctors are willing to listen to patients and to answer any questions that you might have. And then also with multiple myeloma specifically, having a myeloma specialist is very important. In fact, research has shown that life expectancy is better, outcomes are better, prognosis is better if you have a multiple myeloma team working for you. So those would be some of the things I would suggest.
Dr. Abdallah, what would you like our viewers to take away most from this conversation?
Absolutely. I mean, I think that, you both covered everything, so I'll tell you, like, mainly as a doctor, as a myeloma doctor who's passionate about the field, and I'm hoping that we're going to find better treatments and cure, because that's our aim. I want to retire while I see myeloma cured. I think that's the best retirement plan I will have, But, I mean, getting clinical trials for KU is for our patients in Kansas. That's why we're bringing these trials. We want to try to give them the trials so that they don't have to travel to Mayo Clinic or MD Anderson to get the same trials that they're, and we are developing a lot of CAR T-cell bispecific and even newer treatments, so the whole purpose is that, don't feel free always to ask our team about the clinical trials. We're hoping that, we will make sure we have everything covered in terms of the myeloma treatments.
Doctor, thank you for taking your time today. You've been very generous with your time. Lou and David, thank you for coming on to share your journey.
Happy to be here.
It's a journey everybody can learn something from, and thank you for all the work you're doing to support others.